How do we manage patients with type 2 diabetes in the hospital? Do we just continue with their oral diabetic medications or do we switch them to insulin? A 45-year-old male patient is admitted for COPD exacerbation. He takes metformin and atorvastatin. His latest A1C was 7% a month ago. Do we continue his metformin on admission? It is generally advisable to discontinue all outpatient oral diabetic medications when a patient is hospitalized. This step is taken to prevent potential drug-to-drug interactions or adverse events. If the patient is already on insulin at home and not under NPO or maintaining a good dietary intake, it is also recommended to continue the same insulin regimen during the hospital stay. There are three types of insulin. Basal insulin is a long-acting insulin that effectively suppresses hepatic gluconeogenesis during periods between meals and overnight. Bolus insulin acts more rapidly and addresses postprandial hypoglycemia. It is administered about 20 minutes prior to a meal. Additionally, there exists the concept of an insulin sliding scale, now commonly referred to as correctional insulin. It is advisable to exercise caution when relying solely on correctional insulin as the only treatment, especially in cases where the patient experiences persistent hypoglycemia. How much insulin should we order? If a patient is not on insulin at home and we have to discontinue the patient's outpatient oral diabetic medications, we use the formula 0.2 to 0.5 units per kilogram per day. Divide by half for the basal dosing and mealtime dosing, which is then divided into 3 for breakfast, lunch, and dinner. It is also important to note that if the patient has a high risk of hypoglycemia, such as elderly, frail, a low BMI, a patient not eating, then we use the lowest number of 0.2 units per kilogram per day. If the patient has a low risk of hypoglycemia, such as younger patients or obese patients, then we use the higher number of 0.5 units per kilogram per day. Consider a scenario where a 45-year-old individual has been admitted for COPD and maintains a weight of 100 kilograms. This patient currently follows a medication regimen involving metformin and glipizide. As part of the inpatient management plan, all oral medications will be temporarily suspended. Instead, an insulin regimen will be initiated, utilizing doses of 0.5 units per kilogram per day. This insulin regimen will involve approximately 25 units designated for basal insulin. Additionally, around 6 units of bolus insulin will be provided in conjunction with meals to manage postprandial hyperglycemia. Let's consider a situation of a 45-year-old male patient who has been admitted for pneumonia. This individual is currently prescribed Levemir at a dosage of 10 units, along with Lispro at 8 units with meals as part of his home medication regimen. How should we proceed in this scenario? The decision is to maintain the patient's existing insulin regimen without alteration. Now that we have established an insulin regimen, we have to have a glucose goal. Generally, our aim is to achieve a fasting glucose level below 140 and a random glucose level of less than 180. How should we respond if the glucose values fall either below or above the target range? If the morning glucose reading is elevated, the appropriate action will be to raise the dosage of your basal insulin. In the case of a high pre-meal glucose value, consider increasing the bolus insulin dosage for all 3 meals or solely for the meal preceding the reading. What about a 45-year-old female admitted for DVT? She is on Glargine 8 units at bedtime and Lispro 8 units with meals in the hospital. Her finger stick glucose before meals are 200 before breakfast, 120 before lunch, and 130 before dinner. In this case, we'll increase Glargine dose and keep the same dose of Lispro. In the general guideline, it is advised to maintain blood glucose levels within the range of 140 to 180. In instances of hypoglycemia, a reduction of 20% in the insulin dosage is recommended. For basal insulin, consider adjusting the dose by 10 to 20% every 2 to 3 days, with the aim of reaching the target glucose range of 140 or less. When it comes to bolus insulin, modifying the dosage by 1 to 2 units per dose every 1 to 2 days can be effective in attaining the desired glucose target of 140 to 180. Let's revisit the case of the patient admitted due to COPD exacerbation. In this scenario, the patient presents with underlying diabetes and has already been initiated on a basal bolus insulin regimen. Now, with the consideration of starting steroid therapy, there emerges a concern about the potential for steroid-induced hypoglycemia. Steroids can lead to an increase in insulin resistance, resulting in elevated postprandial glucose levels. To address this, a once daily dose of NPH insulin is incorporated into the existing basal bolus insulin regimen. The choice is based on the alignment of NPH's peak effect with the hypoglycemic peak often seen in response to steroid use. Generally, the formula of 0.3 units of NPH per kilogram of body weight is utilized. Alternatively, some literature correlates the NPH dose with the steroid dosage. For instance, if the patient is taking prednisone at a daily dose of 40 milligrams or less, a starting NPH insulin dose ranging from 0.1 to 0.2 units per kilogram is recommended. However, if the patient is on a higher steroid dosage, initiating an NPH insulin dose of 0.3 units per kilogram is advisable. In conclusion, effective insulin management within a hospital setting is paramount for patients with diabetes, especially when dealing with various medical conditions and treatments. By carefully tailoring insulin regimens to individual needs, closely monitoring glucose levels, and making necessary adjustments, healthcare providers can strive to maintain optimal glycemic control and improve patient outcomes during hospitalization.